Well, thank you, Dr. Abdulaziz and Dr. Jarvis, Mr. Magdi. It's a pleasure to be back in Doha and to have the challenge of beginning this symposium with a presentation regarding the staging of heart failure, the clinical staging of heart failure, and the implications in terms of diagnosis and treatment. We'll start perhaps with the fact that we've had guidelines since the 1990s in this field, both from the US and from Europe. But really in the last 8 years or so, they have accelerated because of the increasing evidence base. So we have the 2005 guidelines from the US, followed by the 2005 guidelines from Europe, 2009 update of the US guidelines, followed by the 2012 update in Europe. And just last week, the 2013 guidelines were published online in the US. So this is rapidly accruing new recommendations based upon the rapidly accruing new data. The U.S. Recommendations have been based since 2005 on the staging that I've been asked to talk about. And the issue here is that heart failure comes in various shapes and sizes. We're going to focus primarily, especially tomorrow, on the very sick patients with very advanced heart failure. But the recommendations are to begin to identify patients early on who are at risk of developing heart failure. That's stage A, patients who do not have heart failure, but have underlying conditions such as coronary disease, hypertension, or diabetes that might ultimately lead to heart failure. Stage B would be those patients who have, based upon those risk factors, already developed structural abnormalities, left ventricular dysfunction, but are still asymptomatic. Whereas stage C would be the patients who then progress to symptomatic left ventricular dysfunction, either currently or previously. They may now be asymptomatic because they're being treated appropriately because of their response to therapy, but they're responding to standard therapies. And finally, stage D, where we will focus intensely as part of this symposium, would be those patients who are not responding, who have progressive left ventricular dysfunction and progressive symptoms, very limited, not responding to maximal available therapies. And so this affects various portions of the population. So these numbers are based upon the US population, where there are probably 62 million people. That's almost 1/4 of the US population has stage A risk factors. 10 million have asymptomatic structural abnormalities, 5 million have overt symptomatic heart failure, and then a fraction of those, but a large fraction and a growing fraction, are the patients who are unresponsive to medical therapies, perhaps 0.2 to 0.25 million people, several 100,000 people in the US alone. So how do we begin to come up with recommendations for the management of these patients in various stages? Stage A, where we have the patients at risk for disease, the goal here is to prevent heart failure. So control blood pressure and lipids in patients with diabetes, so important in your country with the growing number of people with diabetes, controlling not only the sugar but also the blood pressure in patients with diabetes. And in patients who have evidence of atherosclerotic disease, very important to adhere to the secondary prevention guidelines. Not only blood pressure management, but also cholesterol management, exercise, dietary recommendations, etc. But as patients progress and begin to develop structural abnormalities, then we begin to look at the cyclic nature of heart failure and its progression, where a disease, whether it's hypertension or a dilated cardiomyopathy, will lead to a reduction in cardiac output, which begins to activate neurohormonal mechanisms that we will emphasize, which are either adrenergic, angiotensin, or aldosterone, mineralocorticoid upregulation, leading initially to vasoconstriction, increase in the afterload, and further reduction in LV function. when I was training, this was what we thought the cycle was all about, and this is not accurate, because drugs that are principally vasodilators may or may not be effective in halting this cyclical progression of heart failure. And we now know that the neurohormonal activation also leads to hypertrophy, myocardial fibrosis, myocardial damage, which really then leads to the aggressive cyclical nature of this disease. So the targets for our future therapies that we'll be talking about will be trying to address these targets of fibrosis, hypertrophy, myocyte damage at the cellular level. In the meantime, until we have those new therapies, we focus primarily on drugs that affect the beta-adrenergic system, the renin-angiotensin system, and the mineralocorticoid upregulation as well. And so, as patients progress to asymptomatic left ventricular dysfunction, it's clearly based on large-scale clinical trials that we recommend ACE inhibitors and beta blockers for all patients with reduced ejection fractions, because these drugs have been shown in large-scale clinical trials to block those neurohormonal mechanisms, and in doing so, improve function, improve symptoms, and improve lifespan. In addition, patients who are intolerant of ACE inhibitors and have a low ejection fraction also benefit from alternative drugs, angiotensin receptor blockers as well. And so both the US and European guidelines are very consistent about the management of those patients. Whereas less clear are trying to identify asymptomatic individuals who have severely impaired left ventricular function. In this case, a threshold ejection fraction of 30%, who may be asymptomatic, but may be at risk of sudden death. And here there's not good evidence, but some evidence that an ICD, implantable cardioverter defibrillator, may be beneficial in improving longevity. And so if patients are greater than 40 days post-MI, asymptomatic, and have a likelihood of survival for at least 1 year with good functional capacity. This is a 2A recommendation in the US guidelines. The European guidelines do not make recommendations for asymptomatic individuals. A previous recommendation in 2009 was also to consider such therapy for patients who have non-ischemic LV dysfunction, not caused by coronary disease. But this was a Class 2B recommendation, and in the update just last week from the US in 2013, this recommendation is no longer there. So for asymptomatic individuals, the only recommendation we have would be for those patients post-MI with ejection fractions less than 30% that is not improved to better function with medical therapy. Moving on to those patients who become symptomatic with reduced ejection fraction. Again, ACE inhibitors and beta blockers are strongly recommended in patients who are intolerant of ACE inhibitors, either have allergies or have cough. Angiotensin receptor blockers are recommended as the alternative. It's less clear whether an ARB should be used as the primary therapy, as first-line therapy in patients who have not yet received ACE inhibitors. Less strong recommendations from the US and no recommendation in Europe. Mineralocorticoid receptor antagonists, eplerenone, spironolactone, strongly recommended in symptomatic patients who remain symptomatic despite ACE inhibitors and beta blockers. Even functional class 2 symptoms are likely to have a better functional outcome as well as better survival. Strongly recommended. In patients who are intolerant of the mineralocorticoid receptor antagonists, there's some evidence that adding an ARB to an ACE inhibitor and the beta blocker might also be beneficial. And finally, there's less clear evidence in Europe and one clinical trial in the United States using hydralazine nitrates to treat patients in heart failure who have not improved with ACE inhibitors and beta blockers. In the US, this was an African American population. This drug has not been tried in clinical trials in Caucasians in the United States or individuals of other ethnicities, and so the recommendation principally in the US is for African American patients only. because we don't have data in other ethnicities. Less clear whether this is appropriate for treatment therefore in other countries, such as Europe, where it's only a 2A recommendation. In patients who have heart failure but have normal ejection fractions, it's very troubling because we do not have evidence-based therapies that have been shown to be effective as drugs to improve symptoms and improve outcome. And therefore, what one tends to do in this group of patients is to attempt to identify the comorbidities that are so frequent in patients who have heart failure but normal ejection fractions. Hypertension, atrial fibrillation, ischemia, so that revascularization might be important as well. We give diuretics to improve the dyspnea. If we're going to choose drugs to improve blood pressure, then it's intuitive perhaps that ACE inhibitors, beta blockers, and or angiotensin receptor blockers might be useful. But again, we do not have good large-scale clinical trials giving us the evidence base that's necessary, and therefore in the European guidelines, there are no recommendations are even made in the lack of evidence. Finally, for the patients with very low ejection fractions, the indications for ICD implantation would be patients who have either ischemic or non-ischemic cardiomyopathy with ejection fractions less than 35%. Again, likelihood of survival for 1 year with good functional capacity. Or patients who have already demonstrated that they're high risk because they've had a cardiac arrest or have ventricular fibrillation or have hemodynamically unstable ventricular tachycardia. So in the upper box, we're dealing with what's considered a primary prevention of sudden death, and in the lower box, secondary prevention of sudden death. Now, there's complex recommendations for which patients are candidates for biventricular pacemakers or resynchronization therapy. Both the US and American recommendations are to first identify patients who have left bundle branch block, who remain symptomatic despite therapy, ejection fraction less than 35% in sinus rhythm, and if the QRS is greater than 150 milliseconds, this is a strong recommendation. If the QRS is prolonged but less than 150 milliseconds, the U.S. Committees felt that this was lacking strong evidence, whereas in the European guidelines, as you can see, anyone with a left bundle branch block with a QRS greater than 120 milliseconds, which is essentially every patient with a left bundle branch block, might be a candidate for resynchronization therapy if they remain symptomatic despite aggressive medical therapy. In the groups with non-left bundle branch block, you can see differing recommendations here. It's if the QRS is greater than 150, there is still reasonably good evidence that there will be benefits of resynchronization therapy, whereas if patients have narrower QRSs without a left bundle branch block, the evidence is much less strong. Now, these are the recommendations in patients who are quite symptomatic with functional class 3 or 4 New York Heart Association functional class. In patients who have improved symptoms with aggressive medical therapy, who are now functional class 1, there are still recommendations, but they're downgraded to lesser strength of recommendation in patients who are already improving symptomatically, but still have a wide QRS. Finally, to lead into Dr. Kirkland's presentation about the grading and assessment of patients with severe heart failure, the definition of advanced heart failure, to set the stage for some of the upcoming presentations, really defined quite well in the European guidelines. Severe symptoms at rest or with minimal exertion. Episodes of fluid retention or low output at rest. Objective evidence of severe cardiac dysfunction, measured in many ways, such as an ejection fraction less than 30%, a wedge pressure that's elevated, in this case greater than 16 millimeters of mercury, and very high levels of biomarkers that we'll be talking more about today from Dr. Hightam, high BNP or pro-BNP. Severe impairment of functional capacity, measured objectively or subjectively, perhaps the inability to exercise, or a 6-minute walk test that is quite reduced, or a very low peak maximum oxygen consumption, less than 15 milliliters per kilogram per minute. Also, patients who've been hospitalized at least once in the last 6 months because of heart failure, and all of these above features have been going on despite the attempts to optimize aggressive medical therapy. And in these patients, there are indeed recommendations. Certainly consider these patients for transplantation if they are appropriately selected. It's interesting that there's actually no class recommendation in Europe, which is why there's a blank there, but if you read the text of the European guidelines, they're right in sync with what the US guidelines are, which are strongly recommending that patients be at least considered for whether they be candidates for transplantation. Short-term inotropic support is reasonable for short-term therapies. Consideration for mechanical circulatory support also is now reaching the evidence base that is appearing in guidelines as well, and we'll be talking extensively about this tomorrow. Continuous inotropic support as a bridge to therapy is less clear. I think it all depends on how we define continuous and how we define long-term. And in patients who are not candidates for mechanical circulatory support or transplantation, but are not responding and are in this class of such ill patients, there's at least consideration, not a strong recommendation, but at least consideration for long-term inotropic support. As part of this, of course, the patient should be receiving evidence-based therapies, diuretics to reduce congestion, etc. And that's a very rapid run through the staging that we try to employ in our patients and also in our populations to identify those who are at risk, identify the asymptomatic individuals with structural heart disease to prevent the progression to symptomatic heart failure, and then to aggressively manage those patients who do have symptoms to try to improve their outcome. So this is a way to introduce the next several topics, and I hope this will be a good launching pad for the other presenters, and I think we can go right now to our next presentation from Dr. Amar Badr, who will give us a discussion of the heart failure situation and how the team is beginning to identify patients and treat them aggressively in Qatar.